Good evening to one and all. I thank the PPS-STC for the opportunity of giving this timely talk. It was serendipitous that this also coincided somewhat with the creation of a new committee of the PPS-STC headed by Dr. Frederick Kicho, and with your kind indulgence, who will give us a brief overview on this later on. Okay. So for tonight, I will be speaking about the role of the pediatrician in disaster preparedness and response. The first objective of this talk will be to promote or introduce the kids or keeping informed in disaster situations. The module, which was most recently conducted by the PPS, given as an online workshop under the Committee on Accident Prevention, Disaster, Environmental Safety and Assistance, which comprises 4 main modules. The objectives of the 4-part module are stated as follows. First is to enable the pediatrician to be competent in assessing and managing the needs of the hospital and community in a disaster situation. Second is that the knowledge gained will be used to train other pediatricians, especially the residents, in preparedness and social mobilization. And finally, that we are able to coordinate with the disaster response team in addressing the specific needs of the child. For Module 1, the content will give us the general overview of the various components of disaster management with the following objectives. The second module will expound on the importance of planning ahead and preparing for various disaster situations and the proper implementation of triaging of patients for treatment on site and for evacuation and transfer. The third module deals with events that happen in the aftermath of a disaster, specifically detecting, mitigating, and addressing the psychosocial impact on children and adolescents. And finally, for the last module, it will tackle the basic principles of managing toxic exposures. This will hopefully all be summarized in this discussion, and as such, my own objectives for this talk will be the following. To discuss the impact of disasters and its effect on children, increase awareness and enhance skills on disaster preparedness, emphasize the role of pediatricians in the prevention and/or alleviation of disaster situations, and empowering families by increasing their knowledge and anticipation of problems that may be encountered during a disaster. We are all aware of the definition of a disaster and the devastation that it brings with it. It can also be natural, man-made, or even a combination of both. An unfortunate outcome of which will be mass casualties among different populations, including children. Disaster events outstrip the capacity of individuals and societies to cope with adversity and is the convergence of risk and vulnerability. The Philippines is disaster prone. We ranked the first worldwide in 2010 and 2011, third in 2016, and maintained the position up to 2018. The reason why are the following. We are surrounded by warm ocean waters, made worse by the ongoing climate change and global warming. A lot of our countrymen live in coastal areas. There is widespread deforestation. We are also situated along the Ring of Fire and problems of underdevelopment. The Ring of Fire is also known as the Circum-Pacific Belt, and it makes the Philippines and other countries situated along its area very prone to earthquakes, volcanic eruptions, and tsunamis. It is said that we are headed for the big one anytime now. No, it is due anytime. An earthquake with a magnitude of 7.8 or higher. And so hopefully, no, we won't experience that extent of impact of a disaster event. But if we do, unfortunately, since underdevelopment is still very persistent, then we may not be able to adequately cope with the demand that it may bring. Okay, so remember too that we should vote wisely and hope and pray that our countrymen will do so too. So why should we have a disaster preparedness plan for children? Conservative estimates may place the population of children at around 30% of the total population. It has also been evaluated by the NIH and NCD-MPH, or the National Center for Disaster Medicine and Public Health, that there are no established role-specific national core competencies in disaster health for children. In the event of a significant disaster, many of our children will have to be cared for by non-pediatric or generalist trained clinicians such as emergency physicians, nurses, and paramedics, who have variable degrees of understanding of pediatric acute care. And they may also lack or have limited skills to address the various special needs of children. This table summarizes the more important points in assessing the special risks children may suffer from in disasters due to their physiologic vulnerabilities. Unfortunately, we as pediatricians may have lacked in addressing this issue due to various valid reasons. Hence, in times of disaster, our children may suffer even more. In any disaster preparedness program, risk identification is the foremost thing to do. All possible risk factors or hazards should be explored and prepared for. Vulnerabilities in the area, community, or environment which could result in harm should also be identified. Assessment and analysis of potential impact of the event should be performed so that a comprehensive preparedness plan could be developed and later utilized. Remember, or it is said that failing to plan is planning to fail. Disaster preparedness is achieved through community-based approaches and activities like mock drills, preparedness trainings, awareness raising sessions, etc., which minimize the effects of disasters on their lives. As healthcare professionals, it is ideal that we should be involved in these activities. Next, we will go to the different phases of disaster management. It is commonly divided into the following: the pre-disaster, when preparations and mitigation measures are done; during a disaster event, when immediate response is executed; and post, or in the aftermath of a disaster, where there is continuing response and tasks geared towards recovery are begun. In each phase, we will see how we as pediatricians can play an important role and perform specific activities which focus on addressing the needs of the pediatric population. In the first phase of disaster management, before the disaster takes place, which involves preparation and mitigation measures, the pediatrician is tasked to determine the community resources and needs, join community planning by including children's specific needs, and integrate in the disaster response plans. We need to be proficient in cardiopulmonary resuscitation and first aid, train first responders in pediatric assessment, assist in development of pre-hospital pediatric protocols, help establish protocols for consent to treat and identification of minors, and assure the availability of pediatric resources. Families view pediatricians as their expert resource, and most of them expect the pediatrician to be knowledgeable in areas of concern. Providing expert guidance entails educating families in anticipation of events and responding to questions during and after actual events. It is essential that pediatricians educate themselves regarding these issues of emergency preparedness. Some factors to consider in making a disaster preparedness plan for children. Again, as mentioned, the special needs of children need to be considered and understood in disaster planning and preparedness. We should also consider planning for different scenarios: children at home, in school or childcare, in transit, children who cannot be reunited with their families, no, among other possible situations. Plan also for those with special healthcare needs, those who will need medical equipment or other technological aids for survival. Additionally, there may be a need to modify or adapt strategies depending on a particular situation or risks, and we as pediatricians must be ready for that. The importance of having a plan in place before a disaster is obviously crucial in mitigating the impact of a disaster. Here are some useful tips. At the onset, construction of hazard maps assist in the preparation of plans which can reduce the danger in a community and in the identification of evacuation plans for risk areas. Community members, teachers, school children, social and healthcare workers, and others can create these maps using simple and readily available materials. The information that is generated can be used to help plan risk reduction measures and initiatives for disaster preparedness. Separate maps should be created for different entities in the community, such as schools, hospitals, market areas, etc. Include also scenarios for potential hazmat exposures with particular consideration to vulnerabilities of children in these instances and how they should be addressed. Toxic exposures can also be man-made or come about as a result of natural disasters such as volcanic eruptions, earthquakes, which can result in the liberation of noxious gases. So this can compound any previous underlying incident and result in a higher number of mortalities and morbidities. It is also possible that in a particular disaster event, we might be dealing with more than one hazardous material, and the approach we have to adopt in formulating a plan of action should address all of them and not just one particular event. Empowering families is another aspect of anticipatory guidance which should be considered, specifically educating them on disaster preparedness, awareness, and encouraging them to have a family disaster plan in place. A family who has a plan ensures protection for each member and minimizes the adverse effects a member may suffer because of any disaster. It also aims to ensure that the needs of most vulnerable members are taken care of. This can involve assessing structures in and within the home and do necessary changes to prevent injury or harm, discuss plan for different scenarios, evaluate and assess the risk surrounding the area, and determine safe places in the house and in the neighborhood. Prioritize tasks within the family or within the home before prioritizing tasks to be done outside. The success of this plan depends upon each member being aware of the plan, knowing the specific roles and responsibilities assigned to them, and practicing its execution. Other aspects which should be included in the family disaster plan are the following. Okay, so determine 2 separate disaster meeting points. This should be discussed. One should be near the house while the other should be far from the house, in case it is not possible to return home. Get information and also participate in training, specifically about disaster preparation and first aid courses. Learn and identify evacuation routes from the neighborhood, and find out how one can get special help for the elderly, handicapped, and where and how to move incapacitated people because of a disaster. Additionally, the family disaster kit should be ready in place for each member, containing provisions, medications, and other important needs to last around 3 to 5 days. A laminated or waterproof ID tag or bracelet with name, contact number, next of kin, address, important medical condition should also be included and should be placed securely on younger members who may not be able to talk in case of separation. For the next phase, during a disaster, some of the responsibilities a pediatrician might take on are the following. Keep a logbook of diseases seen, classify them by sex and age, analyze and share information with the regional surveillance unit, and gather important data. So what are these data? They may be a record of the deaths, significant morbidity or frequent illness in the community, early warnings such as an outbreak of or a single case of an infectious disease such as cholera, other data that needs to be documented are the state of nutrition of the children or malnutrition, infectious diseases such as, aside from cholera, malaria, serious trauma, or other injuries. They are important in order to determine what are the needs that require prioritization and ensure that problems are promptly and properly addressed. Triaging during a disaster is also important, and we can also participate in this activity. So it is done to ensure that the delivery of care to patients is maximized. They are color-coded or tagged as follows. For those that are who are uninjured or have minimal injuries, they are tagged as green. For the yellow tag, they are those who are moderately injured or have urgent conditions that needs medical attention. For the red, they are the more severely injured or emergent cases, and the black tags will be those that are already dead. Based on this color coding scheme, other medical personnel and first aid responders will be immediately aware of the clinical status of a particular patient or child. One should have a proper evaluation of the patient's condition in 60 seconds or less. We should remember the acronym START and RPM as aids in prompt evaluation. However, bear in mind that this can be effectively utilized for children 8 years old and above. For much younger children, this may not be suitable because of the following. The respiratory cutoff rate of 30 per minute is not applicable for perfusion status. Capillary refill time may not be helpful, especially in cold environments, and evaluation of mental status may be more difficult. Hence, we employ the Jump Start triaging system for younger children. Again, those aged 8 years old and below. The Jump Start categories for triaging children is shown in this slide. Transport of patients are also color-coded, and prioritization for need of transport services are based on this color coding. Infant and young child feeding is extremely important, more than ever during a disaster event. As pediatricians, we must all do that we can to participate in or conduct activities that would promote this goal. Practices such as exclusive and continued breastfeeding among them. We may also actively take part in activities such as these to address and control infectious outbreaks. Disasters, be it natural or man-made, may also result in toxic exposures. We've mentioned that in such cases, always bear in mind that the first priority should be to ensure the safety of medical personnel, since if they are compromised, casualties due to the incident may be even greater. The importance of strict security measures and the use of the proper protective equipment depending on the hazmat you are handling or dealing with is also important. As well as establishment of specific zones so that everyone is aware of the present threat and prevent others from wandering into the hot and decontamination zones where they may be exposed. With regards to other important things to guide us in responding to toxic events, it is also prudent to be aware of the various venomous animal population in the area, since they may also be displaced because of the disaster event and wander into populated areas they would usually avoid. And, of course, always remember that treat the patient first and not the poison. In the last phase, during the aftermath of the disaster, so this involves continuing efforts, response efforts that were initiated during the disaster, and this also coincides with the beginning of recovery efforts. So usually this will be from day 3 onwards. At this time, we can continue to implement the plans instituted to address the health, nutritional, and developmental aspects of our children and address concerns regarding logistics and resupply. Aside from this, an integral part will be evaluating and managing the emotional and psychological disturbances suffered by children. Play therapy is a valuable tool to aid in this aspect. In the aftermath, the pediatrician will continue to give anticipatory guidance, manage early disturbances. They can also help screen for disorders. They provide less intensive intervention, being someone to talk with or get advice from is an important aspect of counseling. Okay, so based on our interactions, we may also get a clearer picture on who needs referral for mental health and community-based treatment. And an unfortunate task that we may also have to deal with will be the notification of death. Children and adolescents have emotional vulnerabilities, and especially when they are subjected to harsh conditions or experience severe trauma. Okay, so especially when they are direct witnesses to the impacts of a disaster, they may have longer exposure to changes in everyday life, exposed to extensive damages, or they may constantly perceive life-threat scenarios to self and family members. Those who will be at risk are those also who survived, those who survived with more physical injuries or experienced death in the family or may be separated from their loved ones. Okay, so we may need to foremost identify those who are at risk. Children being too young or inexperienced to comprehend and understand how an event has occurred will look to adults in their life for a cue on how to react and process the event. It is likely that the parents will also be affected, in which case medical personnel, members of civic organizations, school teachers or other school officials, or members of other teams and organizations can play an important role in providing a safe and familiar environment. Symptoms such as sleep disturbance, behavioral changes, loss of appetite, etc. So they may appear, but if they do not impair normal childhood activities, they can be considered as part of the normal recovery process, and they are expected to disappear after some time, no? But the persistent disturbances are considered as pathologic if they persist for more than 6 months and affect return to normal function. Pediatricians must be aware of the varied normal patterns of behavior to distinguish normal from pathological behavior. In any setting, identification and timely intervention of behavioral problems is crucial to recovery and normal development. It is important to recognize and address disturbances noted in children to help them cope and understand the situation. They may be age-specific, and another important thing that we need to do and prioritize is that families should be brought together. No? If children are separated from their parents or families, all measures should be undertaken to bring them together. For elementary school children, again, they may experience irritability, aggressiveness, nightmares, withdrawal from activities, and adolescents may also have the same complaints, okay, or they may result in delinquent and aggressive behavior, among other things. So it is well known that mental health is a major health concern among children and adolescents, especially during disasters. The most effective way to prevent persistent and long-term disorders is to address and to mitigate emotional impact at an early age, and psychological first aid is an essential practical approach which we can do as pediatricians, and it is utilized as an initial management in distressed children. So these are some of the first aid techniques, no, that we can employ. Again, being helpful, being someone they can trust or someone that they can talk with, no, but we should not pressure them to talk. No, just making them feel protected will provide a lot of help and reassurance to our disturbed patients during a disaster event. Factors which help children cope better. Of course, it's important again, no? We always emphasize social support from family and friends, specific activities like asking the children to work together in groups, and getting back into the normal roles and routines that they had or they did before the disaster is also very important to establish a sense of normalcy, no, and return to normal. The things are already getting better. So those are the aspects that will help children cope better, as well as encouraging them to talk about the disaster or asking them to take part in other activities, no, nonverbal activities like drawing, painting, verbal activities such as storytelling and other means of expression. And a more direct and helpful method could also include talking about other people and children who have experienced similar natural disasters, maybe in history or in contemporary times, and the emphasis should be on how these communities and people recovered. Okay, factors which can delay coping and recovery are the following. So once they are detected, they should be immediately addressed, no, so that it will not persist in the thinking of the child, no. Otherwise, it will burden them, and they may carry this burden throughout their lifetime. Okay, so this is a summative overview of the tasks that we can get involved with as pediatricians during the recovery period. So we continue to monitor and evaluate the nutritional status of children, requirements for growth, development, okay, learning, psychological problems, psychological status, okay, and collaboration with government, NGOs, or community-based organizations are also very vital since they may already have a structure in place, and working together ensures greater success at achieving our common goals. In summary, helping children cope with disasters is not a short-term intervention. As with all contingencies, a plan of action should exist before the event. Close monitoring, particularly those with increased risk factors, should be done to determine long-term assistance. We should also always foster resiliency, foster or promote a sense of security, and enable the child to appropriately process the event. Additionally, as overall recommendations, we should advocate for the inclusion of the needs of children at the national and in all local disaster planning. Pediatricians and our trainees, residents should become knowledgeable in issues related to pediatric disaster management, including a wide variety of instances, be it chemical, biological, radiologic, etc. We should also participate in disaster planning in our community and local and hospitals. We may even be the ones to initiate them, conduct drills through emergency medical services, prepare and regularly update and practice an office disaster plan. We can also work with schools and child care centers in developing disaster plans. And a very important aspect is providing anticipatory guidance to families on home disaster preparedness, in how to prepare their own family disaster plans, with consideration given to the unique problems faced by children with special health care needs. Okay, participating in disease surveillance and reporting to local health departments. So these are activities that are important during and after a disaster. Participate with and provide guidance to medical volunteer programs such as disaster medical assistance teams, medical reserve corps, and other response teams to ensure that they are equipped and trained for the care of children. And last but not the least, we must also protect ourselves, especially from liability issues, by studying local and Good Samaritan statutes and protection, harm and disability. Ideally, we should have healthcare coverage, or protection when providing urgent care outside our usual scope of practice. And as such, it might be best for us to work under the auspices of an official government or disaster agency, where volunteer liability protection may apply. With that, I hope that I have been able to fulfill the objectives of this talk. In behalf of the PPS-STC Committee on Disaster Preparedness and Response, I hope to work with you for future undertakings. I believe Dr. Fred also has something to share with us, and so I thank you for your attention. Happy planning, and may we all stay safe and healthy. Good evening. These are my references for this evening's talk.